So I'm going to introduce our paper which seeks to understand and explain the differences between good and poor care for heart attack patients. So the study started from the observation that you're more likely to die in some hospitals than others from your heart attack, and we wanted to find some new explanations for this observed variation. We did a comparative ethnography in 10 hospitals with a range of characteristics and mortality outcomes. And as we analysed the data, we came to feel more and more strongly that differences in care had something to do with all the different boundaries in hospitals. We felt boundaries were very relevant to hospitals. There are lots of different specialists coming together and professional groups. There's fragmentation, hospitals are very hierarchical, and there are lots of spatial barriers. For example, heart attack patients start in the emergency department, but they have to be transferred to catheter labs and cardiology departments. Our key argument is effective care occurred when heart attack patients were enacted as boundary objects. And this statement is based on our observations of the contrasting care for the two main types of heart attack. So one type of heart attack is easy to diagnose and treat. We observe lots of different specialists coming together effectively to care for these patients. They were consistently prioritised. There were lots of good examples of well-coordinated care. And we propose these types of heart attack patients as being straightforward boundary objects. The second main type of heart attack is more difficult to diagnose and treat. We saw many examples of poorly coordinated care. The boundaries between different professional groups, different departments, traditional hospital hierarchies all seem to get in the way of good care. We propose these heart attack patients as having uncertain boundary object status. There were a few exceptions, for example, when specialist cardiac roles really allowed staff to champion the care of these patients. And then when they got the specialist support, we felt that these patients were elevated to boundary object status. So what can we learn from all this? Well, care generally seemed to be better when heart attack patients received additional and coordinated attention once they were enacted as boundary objects. So we're not saying that patients are viewed or treated like objects in hospitals, but we are saying that there is useful learning from boundary object theory that is relevant to organisational problems such as coordinating complex patient care. Thanks for listening. Please get in touch and please read our paper.